I think we have to think about the people who are not there. Okay, it's my really great pleasure to invite Norman Sartorius to give a talk today. I think some people have said that Norman Sartorius is a rock star in psychiatry and doesn't need any introductions. I think he has been born in Germany, and I didn't know that for a while. And I think he had been in Croatia and has been working quite hard to become a psychiatrist. He worked with the WHO and became professor at several universities. And he is currently the president of an organization he organized himself. He's president of the Association for the Improvement of Mental Health Programs. And as I said before, when we had a chat, I think he's one of the great psychiatrists and one of the most eminent and I must say also entertaining psychiatrists. So Norman, thanks for coming on to our online meeting. And if you want to start your talk, that would be great. Thanks so much.
Thank you very much for inviting me. It's nice to see some of my colleagues whom I don't have the pleasure of seeing so frequently, and I hope that there will be many more meetings like the one which you are organizing, which will overcome the relative isolation that has occurred because of the various recent developments, in particular the COVID pandemic and its consequences. Now, I'll speak about the psychiatry and medicine of the future, but in order to do this, I would like to first remind you that there are certain trends which are currently affecting society. And I'll speak and say a few words about each of those trends, because I think that in one way or another, these trends affect what we are doing, they affect what we should be doing, and they affect the training which we should be giving. And I think that they are of tremendous importance also for the mental health of the population of the world. And I've listed them here. This is the urbanization and the others that are listed here. And I'll say a few words about each one of them. Urbanization, at first glance, you would say that maybe this is not directly related to what we are talking about, but it is enormously related, because the rapid urbanization, which is currently going on, has in fact done so many important changes in society. It destroyed what we considered to be a community, which can accept somebody and look after him and provide care and understanding. And communities exist in a different age. They existed until very recently, but now, as the urbanization progresses very rapidly, most of the people who live in towns, they do not know each other. They have no contact with one another. And in a country like Argentina, for example, now up to 95% of the total population lives in towns. And most of those people have moved to towns in the last 20 or 30 years. And that, of course, means that we suddenly find ourselves with a task to provide healthcare, forgetting the notion of the community. Professor Hoyne will undoubtedly recall the tremendous credit that has been given to Professor Griesinger, who in 1842 introduced the notion of community psychiatry, and the way, and he said that it's ridiculous that people should be treated and kept in hospital forever. He wanted to release them in the community, but now suddenly it is impossible to find a community, and these communities do not exist any longer. There are some surrogates, not very good surrogates. For example, the surrogate of the electronic community, and this is a very nice, but it does not really help people who are ill, particularly if they're mentally ill. And people are, in addition to this, in these large cities, very lonely. In a recent survey of population in a census in England, it showed that London, for example, had up to 1/3 of the total number of households were single-person households, people living alone with very little contact with anybody anywhere else. And of course, because of this splitting of communities, the burden on carers who live in towns is becoming much larger, because on one hand, they have to deal with all the specific tasks which living in towns requires, but at the same time, they have not much contact with anybody else. And we see that this is, among other things, also reflected in a much reduced rate of children, having children, their higher divorce rates, and the change in the way in which the people talk and think about one another. The other consequences for health of the urbanization, and one in particular one is the one which we have just experienced now, is that as towns progress and the surrounding of the town, the forests, etc., are gradually disappearing in the process of deforestation, many of the animals that have previously lived in these forests are now coming to live in town. And there are a number of species that have now almost completely moved to towns. Bats are among them. I'm mentioning bats because they are very similar in their structure to humans. And many of the viruses that, or other causative agents of diseases that bats are having are also very much causative of diseases in humans. And the most recent COVID is a good example of that. And there's a number of others which should follow. A colleague of mine who is a specialist in questions of viruses, he has counted about 30 to 35 viruses which are currently residing in bats and are likely to be of danger to humans. And the bats who are now living in towns in huge quantities, one of the less well-known consequences of deforestation and urbanization. There is also the number of people who are living close on top of each other increases the number of contagious diseases, which are, once they start happening. And on the other hand, we have to admit that urbanization allows more easier access to healthcare, but unfortunately, in most countries, it allows this to those who can pay for it and not for everybody who needs it. Now, the second trend next to urbanization, which I think is important, is a trend of what has been called commoditification. You will not find the word in a dictionary. It's a neologism which has been invented by a person who worked at the World Bank. And he has, in fact, used this word to express a current tendency to consider everything as a commodity, like sugar or iron or cotton or timber. You pay for it, you get it. The more you pay, the more you get. If you don't pay, you don't get it. And this is also applied to health. Health is considered as a commodity. You can have to pay for health in order to get some of it back. A judgment about the hospital now, it's a good hospital. It made a profit. Hospitals haven't been intended to make a profit. They were originally meant to provide care about everything. And I think that currently what is happening is that the healthcare, which was in the past an ethical imperative, is now gradually becoming an economical opportunity where people can make a lot of money and can use this health business in order to make this money. Commoditification is also this turning and permanent preoccupation with how much money will I have to invest and how much will come back, has significantly decreased the interest in helping people with lasting impairments, including mental health as well. And it also has led to other reductions in what is called social capital. Social capital, as you will remember, is the sum total of the mutually helpful relationships in the community. As the number of such helpful relationships, like if I help somebody, an elderly lady, to cross the road, I have done a contribution to social capital. But as commoditification strikes societies, the number of these mutually helpful services is decreasing. And so social capital is dropping in its mass, and the treatment and care for people, even if they are not very sick, becomes more and more difficult. So that's the second major trend after the urbanization. The third trend, which is present everywhere, is digitalization. And I think that we can all, we know a great deal. We would not be meeting here if we did not have a chance to join electronically. And that is wonderful. And it makes access to information and the exchange of information much easier and efficient. But on the other hand, digitalization is also contributing massively to dehumanization of care and the dehumanization of human relationships. Previously, when I went to pay to send a letter, I went out and I went to the post office and I spoke to the post office person and I, etc., whole range of engagements. All of these have now become different. I'm not saying that they're worse or better. They're just more efficient, but at the same time require and leads to less human contact, which is very important. And on the other hand, it's also important to say that digitalization has not been equally beneficial for everybody. People who are poor and cannot afford the computer are suddenly deprived of many things that they previously had. Because now it says, just go to the net and to the web, and you will, what kind of web should I go for? I don't know what the web is. And less literate people, who are also very often poor, are equally so handicapped. And so are the elderly, who find it more and more difficult to keep up with the permanent improvements, and which require also permanent updates of our own knowledge, which is not very easy. All of this, I'm saying, perfectly aware of the fact that research, for example, and many discoveries are now possible because it can be, questions can be posed to a very large set of data, huge data sets, which can be exploited to get answers to questions. So, but we have to remember this element of dehumanization, which is of great importance. Demographic change is another of the great trends that I mentioned before. With an increased number of elderly people in every population of the world, a decrease of the number of children, and also a variety of other changes of survival rates. We have to remember that the demographic change, the increase of the number of elderly, has consequences for the health situation, which are very important. For example, we have a significant increase of comorbidity because people at higher age are more likely to suffer from 2 or more diseases. And care for the elderly becomes much more complex because on one hand, we have the urbanization with loneliness, but at the same time, we also have a number of problems that have emerged, comorbidity and loneliness together will in fact create a lot of severe suffering and also death. It's also important to remember that demographic change will increase the cost of health care because with the changes in the epidemiological situation, there are also needs for additional and different kinds of facilities, and that, of course, costs a lot of money. And then there is the process which has recently been called the horizontalization. And the horizontalization is basically a trend to spread information and contact and mutual help within the same layer of age and profession. So that that means that the vertical communication, which previously existed, is less and less often present. So that children today learn less from their parents than they used to. And particularly, they learn less from their grandparents. They learn from their equals, with whom they are very often linked with social media. And they learn from people in their own layer, but the layers do not communicate very well. That, of course, has a huge number of consequences. And in some countries, there is a very worrisome situation. For example, take China, in Beijing, if you take the number of widows and widowers, you find that 70% of them have nobody to look after them. Although they have children in the same town, they have to hire somebody from the villages to look after them and be their partner, companion, friend, or supporter. And even in countries which have been, and China, of course, has been known for its emphasis and pride about the fact that they have been worrying about their ancestors, about the elders, and so forth. In other countries, the same is happening. There's recently been a law which has been passed in Bangladesh, which will punish children who do not look after their children, their parents. It's an indicator, it's a signal that the relationship between the different layers of the population is no longer what it used to be, and it's worrisome because it changes the nature of society to a large degree. It also means that if you want to get an information pass, we cannot anymore expect that the single information left on the spot will be known by all of the layers. We have to think of a reorientation of our health education efforts into horizontal layers. We have to think about specific language that these layers of population, layers of age and profession speak, because they do not understand the language of the other layers any longer. And I think that that is it has a further consequence. Since the layers do not communicate, it is much more easy, much more probable that an infodemic, that is a bad series of wrong attitudes and ideas that follow and accompany an epidemic of the disease, will do. A good example of that has been the infodemic that was going together with the pandemic of COVID, in which there was a huge refusal to accept vaccines and a variety of other things that have been happening because the information did not get through. And when it got through, it was from a different layer and therefore not acceptable and not credible. The relationship between people are also changing. They're not only changing because of the digitalization, but also the doctor-patient relationship are changing in a significant manner because of this somehow difficulty forgetting and unlearning how to speak to people of a different age or a different social class or a different group. One early symptoms of this has been a very interesting study that has been done in New York very many years ago by Muriel Hammer. She at the time was worried, she was particularly interested in the impact of social class on diagnosis. And she demonstrated in a very interesting paper that the probability that the person will be given a diagnosis of schizophrenia was directly related to the size of difference in social class between the doctor and the patient. The larger the difference in social class, the more likely was the doctor not to understand what the patient was saying, wanting, or doing, and therefore more likely also due to incomprehension and being in different worlds, a diagnosis of schizophrenia. Now, of course, the horizontalization is having another effect, and that is that we have to think of fighting stigma, for example, in every one of the layers. Because while one of the layers may be free of stigma or be freed from stigma by our campaigns, you will find that it continues to be present in the other layers. And while maybe people of 18 or 20 or something like that may say, all right, we have been now convinced we will accept people with mental illness, people of 30 and people of 14 are not doing it at all. Finally, there is a last of these trends, which is the trend of decivilization. And decivilization is a term that is related to a crumbling of civilization. And civilization can be measured by of a society can be measured by the amount of care that a society gives to its feeble members, to its elderly, to the children, to the sick. And if a society stops doing it, it becomes decivilized. And that is precisely what we are seeing happening now in many countries. Because the support which is necessary to look after people with disabilities and impairments in the new challenges that are meeting them is in fact reduced in both size and in personal attention. And then of course the decivilization will greatly help the stigmatization which goes with it. And suddenly we are seeing that we have this huge trends which are maybe in one way helpful, praising and promoting self-help and self-reliance instead of thinking of the necessity of mutual help and mutual reliance. It is wonderful if you know how to help yourself, but it's not enough. In many ways, helping oneself very often surpasses the capacity of the individual and therefore leads to failure. Now, in addition to these trends, which I think are universal, there are also other trends in development which are specific to the local culture, to the place in which people live. And so that has to be kept in mind. These trends, which I mentioned, are trends that have been more or less universally observable in most countries of the world. Now, psychiatry, of course, has to continue to exist. And it's quite probable that the pharmaceutical and other industries, for example, the whole new branch of nano industry, will produce many new helpful things, new tools, new medications, new ways of diagnosing. I've just recently read that now there are ways of assessing the risk of arrhythmia much earlier than we ever thought it would be possible. There's a variety of other things that are keep coming to us. It's also possible that the productivity of an individual who is working will increase so much that it will be possible to have a large proportion of the population not working, but enjoying the fruits of labor of those who are those highly productive individuals. And maybe we will also become more aware and more willing to do something about pollution and various kind of human-made diseases which are currently in our presence. But what will happen with psychiatrists of the future? I hope that they will be better equipped and armed with new knowledge, but they will have to face some old and some new problems. And some of these will include, the first one will be the problem of comorbidity, which I think has been enormously present and equally so completely neglected, not completely, but to a large extent neglected. People today have, on one hand, the continuing fragmentation of medicine into ever finer disciplines. There are no internists any longer. There are hepatologists, cardiologists, thyrotoxicosis specialists, endocrino, I don't know, a whole range of sub-disciplines, but no single one. Psychiatry is not much better either. We have child psychiatrists who do not speak to the adult psychiatrists anymore, and the adult psychiatrists, and the old age psychiatrists, and the specialists in early interventions, and so forth. So that while, on one hand, medicine is exploding into these small disciplines, people are suffering from more and more diseases at the same time. They are comorbid because they are managing to survive. The success of medicine made it possible that people become more sick than for more diseases than ever before. So that's a first problem which psychiatrists will have to face. What do you do about comorbidity? The easy answer is, let's do collaborative care. General practitioners will work together with psychiatrists. Well, wait a minute now. First, you have to get the general practitioners to want to do it. And second, you have to find ways of organizing a smooth transition and a smooth travel of patients between people of different, with different diseases at a time when that is becoming more and more difficult. The Americans have even invented a new profession, which does nothing else but takes the patient from one place to another. They're called care managers. But the basic fact remains that we shall have to think in our education of psychiatrists of ways in which we can make them more able to look not only after the mental disorder, but also about other problems, physical, mental, social, which a patient might have. There's also another consequence which is important, and that is there is a multitude of small problems which were previously resolved in large families. A grandfather or a grandmother would offer a warm embrace to a young grandchild who had a big trouble, because she or he, the grandfather or grandmother, were there at home. You could see them and you could run to them. But the number of people on whose shoulder you can cry is becoming lesser in all societies due to the trends that I mentioned earlier. And now these small problems, which were previously resolved in company with other people, are becoming problems which have to be brought to an external person for money. And all of the problems that I mentioned to you earlier are now applying to these problems as well. Then there is the problem which is huge. Societies urbanized with small units living together, get a person who is not well, family looks after him. Maybe very often a woman who looks after an elderly relative, but she also goes out for work, and she has also to look after children, 1,000 other things. And there are so many things that there is currently, and what we almost call a growing epidemic of burnout. They just can't do it any longer. It's too much. And we have seen that there are some signals of that which have been present for a while. For example, that people who have a chronically ill person in their care have more physical illness than people who do not have such a person in their care. Physical illness of various types, sort of a diseases which are due to reduced resilience and people who have somehow an emotional emptiness. All of this is leading to an epidemic of burnout with all of its consequences that are there. This makes our work on raising resilience and on health states of people who look after people all the more important. It's also true that we shall have to think of ways in which we can learn how to deal with machines, which become more and more frequently used. And each one of those machines is as good as the user. Many of them are in fact replacing older machines, and that requires extra training. So we'd have to think of a very sophisticated and regular manner of retraining people. The current system by which you get some points if you go to a congress is of no value in this respect. We shall have to think of making sure that people grow with time, that they remain, in fact, aware of things, that they remain of the potential that exists in the new machines, in the new tools that medicine can use. They will have to also learn other things, and in particular, doctors will have to realize, particularly psychiatrists, will have to realize that many of the things that they can do will not depend on them, but will depend on others, on convincing others to do something. Psychiatrists, for example, should be the ones who will convince the decision makers in the government that they should provide iodine to women who are in pregnancy. Because iodine deficiency will create a significant mental and neurological problem of cretinism. And there are millions of people who are still born with cretinism because we have failed to communicate to the decision makers in this way. And of course, psychiatrists and physicians in general will also have to remain able and willing to participate in research that will allow them to judge properly what the new options which are before them, mechanical and humane and human, are in fact worth it. So in order to prepare ourselves for this new world, we shall have to, number one, very seriously revise the way in which doctors are selected. It should not be selected because they have the best notes. In some countries, there is an interview or several interviews for students who come to enter medical school. In many countries, this is not the case. You enter into medical school either without any exam or with an exam that tests your general knowledge. That is not a way to select doctors, because these doctors of the future will have to deal with the problems of yesterday, who are still remaining, problems of tomorrow, and their responsibilities and their emotional and social capital must be incomparably larger than it was in the past. We shall have to, once we have selected people who have a, or rather, shall we say, once we have advised people who are not suitable for medical job not to go into medicine, we shall have to think of how to produce undergraduate and postgraduate education in a new way. Undergraduate education, for example, in most countries of the world, are still done in single teaching. All of these people with the fragmented medical specialists, they teach their business, but nobody does it at the same time for the whole human being who is in fact in front of you. Not only are the teaching separate by discipline, but in addition, teaching of the health stream never happens together. There are very few courses in which nurses, doctors, social workers, health layers, managers have joint training in which they can together learn certain things and ask questions. But not only that, in addition, in which they can become more respectful of the others and learn how to appreciate these other students who are with them. There is a variety of other things that we should do in education. Another small example is to think of who is the best person to teach about home care. We are having doctors who teach it, but doctors are not looking after these people. Usually, if they have a sick person in their family, they hire somebody to look after him. Or they have one of them partners, usually the woman, is at home. So that the doctor gives advice about how to look after a chronically ill person, doesn't have any personal experience about doing it. So what can we do about it? Well, we can maybe invite parents and relatives of people who look after severely ill people to come and teach medical students as a regular course. Because on one hand, they will get the best information of the students, but on the other hand, we shall also recognize the merit that these people have in doing what they're doing, and that may reduce their burnout in turn. We should also have to think about how to best educate people about health, because the current forms of health education which are being promoted and health literacy are not particularly helpful. We have shown in a number of studies, in particular studies that we've done in the framework of the anti-stigma program, that an increase of knowledge is increasing stigma of mental illness. Because a phenomenon that is known to all of you, I presume, which is called selective perception and selective memory. A person who has a very strong prejudice about a particular phenomenon, when he listens to a message of health literacy, he only remembers things that support his prejudice, and the rest he discards. So if you come to a group of people of prejudice and you tell them, among people with schizophrenia, 5 out of 100 will commit a crime, while people without schizophrenia, 10 out of 100 will commit crime. The only piece of information which they will remember is that the 5 commit crime. They will not remember the other figure because it's not touching the prejudice as such which they have. So we have to think very carefully about ways of changing the strategies of stigma. We've just published a book about the new strategies. It was necessary to publish it because there are so many new things that we have learned about dealing with stigma. And I think that that's something that we will have to think about, thinking from early on, how to make children accept imperfection in themselves and in others and still live with them. And I think that that kind of education in which all will together participate, the school teachers and doctors and parents, etc., is something that needs to be developed and will require a lot of effort because it's not an easy thing to do. I think that it's important to think particularly about the education about health, because a significant portion of training about health must have at home in the first days, because most of the stigmatizing, most of the concepts in general are created and become stable in the 3rd, 4th, and 5th year of life. A child of 3 or 4 creates concepts, and these concepts enable him to simplify the world which is among them and around them, and that makes it possible for them to progress. To give you a simple example, a child is faced with many animals of different size. Some are big, and some are small, and some are dangerous, and some are waving their tail. And all of these animals, although they look completely different, have one feature in common: they bark. And so a child knows that, thinks that an animal that barks is a dog. And it has simplified all of these very many different animals into by a single characteristic that keeps them, makes it possible to gradually understand the very complicated world by creating concepts of the environment in which they live. And one of the concepts is the concept of the mentally ill, of somebody who is mentally ill, which is usually combined with danger. This is a dangerous person. But that idea about whether this person is dangerous or not is not created at the 20th year of life. It's created before school begins. And I think we have to think of ways of gradually introducing training about vital things in life, like tolerance of the others and help to others at the element of parenthood. And therefore, of tremendous importance will be the notion of education of parents and so forth. Another thing which we'll have to do is we shall have to accept that the personality traits and motivations of people are usually stable, and that will be tremendously important in selecting future students of medicine. And we should also include much more attention to what Frank has called many years ago non-specific aspects of treatment. He spoke about 3 aspects of treatment. First is the effect of the drug, or rather treatment. Second is the placebo that accompanies. And third is the non-specific aspects of treatment. What does that mean? Well, it's the respect for the dignity of the patient, the willingness to listen to the patient and find a solution that is for a problem that is acceptable for both, and a number of other things, the way in which the hospitals are arranged, the way in which one copes with ignorance that people might have, and so forth. Now, in order to do this, be useful in this, psychiatrists of the future not only do have to be trained as all other doctors, but they should be extremely good users of communication skills. They should, in addition, they should know how to speak, they should know how to communicate, they should know how to listen, they should know how to bring people together. All of these are communication skills and social skills which they should be taught in medical school. And they should be competent in the basic care of people, regardless of the type of illness. They should be able to treat comorbid physical illness while they're dealing with their mental disorder. Not all of it, and sometimes they will have a good link to a general practitioner, etc. But they should not be ignorant about that, as they are at present very often. In their own field, of course, they must be competent and keep up to date. They must also be willing to remain involved in the life of a person after his disease is over, because the disappearance of the disease is not the end of the story. It's the re-entering into life, which I think can be to a large extent dependent on what psychiatrists tell their patients and the ways in which they introduce the recovery process, which is so important. And of course, the fact that psychiatrists are selected differently means also that they should be people who have empathy that they can have for those whom they treat, for carers of those whom they treat, and for people with whom they work, because that is just as important. So, ladies and gentlemen, I think that the future will bring us many changes. Most of them can be predicted very easily today. The focus of work will change, and many tasks will change, but certain things which are of great importance will remain relevant. Among them, I'm emphasizing not only the technical competence, but also empathy for people with whom you deal, with whom you work, and who are to be, in fact, the recipient of what we are doing. And we could probably make life better for everybody if we changed our training now and changed it had the courage to change it in a significant manner. Because if you don't do it, I think that will be bad for the future, but it'll become worse and worse even in the time in which we are living now. So I thank you very much for your attention. I've touched many things without developing them further, but I hope that will be helpful, will make you think about some of these things as you are going on into the future, which I hope will bring you all the luck and good things that there are. Thank you.
Okay, thanks, Norman. And I must appreciate, I'm really impressed with your talk. And if I just, it gives me so many ideas, and I'm very pleased I stored it, or we recorded it, and I can hear it again. But the one thing is, I think, isn't it about lifelong learning? And just doing things all your life, and let's say it that way, being a grandfather as a professor or something like that, and then teaching. And I think when I see my parents, who are possibly a bit older than, so they're in their middle 80s, and the question is, I think their pensioning and going into pension hasn't helped them, because they drop out of society, and what they could give to whatever to the children, that's gone lost. And it's gone lost, because people move to different places. I think you haven't mentioned migration in the same way. So the question is, migration is a big problem, because you have this type of horizontalization, but it's also migration which tears family apart. So I think the question is, how much is it that lifelong learning and non-pensioning or abolishing pension might be something we should do?
Yeah, Well, I think that the whole notion of pension is one that would probably have to be re-examined. The pension has really started with Bismarck. And Bismarck, at the time, was a German politician who has, at the time, wanted to make sure that public servants have something on which to live after they stop receiving the salary. So he has calculated and established that the total duration of life after the cessation of work is 18 months. And since these 18 months have been 18 months which are, it was logical to provide some money so that they can pass away peacefully. Meanwhile, the life after retirement has gone to 20, 25, 28 years. So that suddenly, instead of having a small help to a person who is about almost there to approaching his deathbed, has now been turned into a period of which is very long, and which for the moment we are not quite sure how to structure, because they are not allowed to work for money in many places. I mean, it's very difficult to get an employment or to continue working for free. Many universities are very happy to get rid of you because you are now reaching the age of retirement. Thank God we got rid of you. But there should be ways in which this life, this chunk of life, could be filled with some contents which would be socially useful and personally acceptable. That's one aspect. And the second hole which is existing is the invention in the last few years, invention of adolescence. Adolescence never existed in the history of the world. It was never there. A large proportion of people went until the age of 14, started working, either in the field or in a particular profession where they became apprentices and then learned gradually how to become somebody. So that they were socially responsible, they had a responsibility of some type. Some of them went to school a little bit more, and they had to learn very hard. And during that time, their parents were supposed to pay for them, but only because it was accepted that that period will not be. Now, suddenly, we are faced with a very large proportion in every country of people between the ages of, I don't know, maybe 10 to 14 and 24, in which they have no social responsibility whatsoever. The social responsibility of adolescents is reduced to a minimum. And we have not really developed a sensible way to organize adolescents. And therefore, most of the adolescents have more problems, and we have more problems with the adolescents, because that is a period that has to be structured differently from what it is at present. Now it's left, they just go to school perhaps, but not all of them, etc., etc. So those are the two periods that need a restructuring in a new world, both the adolescence and post-retirement age.
Can I ask Seshni to ask the question? Seshni?
Yes, thank you, Reina. Thank you so much, Professor Sartorius. That was an amazing, brilliant talk, and I'm sure everyone on here agrees. There was so much of wisdom, and your reputation precedes you. So thank you so much for that. And as Daria was saying, we all really love you and all the contributions you've made to psychiatry. So with regards to the question, there were so many take-home messages in terms of education. I think you're emphasizing communication skills, empathy. And I think the thing that I wanted to ask more about, and you may not be able to answer it fully, but it was about the artificial intelligence. And you did talk a bit about it, but you spoke about it in the context of choosing the right candidate in medical students, and how they would need to have an extra additional background about computers and a bit about AI. So, but for those of us that are already in the system, how can we embrace AI and technology and use it to our advantage in our current practice? Well, thank you.
I think that there is two or three things which are very important. On one hand, we have to recognize that most of us are beginners in the art of living a world in the 21st century. We are doing it, but there are so many things that in which we have not been trained, and we couldn't be trained in that because things have developed after our training has been completed. So that there are many things about which we do not know enough. And I think my answer to that would be the crucial and important crucial importance of modesty, of recognizing that we are ignorant, recognizing that we do not know, but more than recognizing that we are ignorant, the readiness to accept training from somebody who until now has never been training us. I think that some of the medical students of the first year can train a professor in many matters related to electronics or in artificial intelligence. It's their world. In their world, and they grow with it, it goes so easy. It would give them, I think, a function in life which is more useful. They would be, in a way, they are translators of the modern world into a world that is already gone. Because I've grown up in a world which was different. And now I'm finding myself faced with many problems in which a young and now this happens by luck in many people. Some people have children who want to tell them, and some people have colleagues who are willing to do it. But I think it could very well be institutionalized. It is foolish to expect that you will get credit by attending a congress. You get extra hours. That's not important. What would be important to learn how to do some of the skills in a course that is organized for that purpose. We are doing courses now regularly in various countries, which are courses for young psychiatrists in leadership and professional skills. And there are skills which are very often, I think, Daria Smirnova, who is here with us, was on one occasion attending one of these courses, and many other people have. And I think that the courses are attempting to provide some of the elementary skills. It's just a small number of them. And my hope would be that we would enlarge that training and skills to become a very important part of the normal training at undergraduate and postgraduate level. Here on this occasion, the teachers being selected because they have the skills and they can show how to use them. Skills cannot be learned in theoretic. You can learn facts from books, but skills you have to learn from teachers. And I think that that's something that has to be a little bit more, given more attention, so that the teacher who is a good teacher, and we can judge who is a good teacher very easily, can in fact transmit some of the skills which he has. At the level of the university, one of the things that one would like to see happen is that a person who is being competing for a professorship should show that he can teach. He never does. He brings along a large number of papers that he has written, which is wonderful because he's a good scientist. He brings along a long list of grants which he has been given, which is wonderful because he's a good grant obtainer. And he brings along a variety of diplomas from other places which show that he's a very good student. But he should have the capacity to teach, to infuse, to lead, to bring people forward, because teaching is not equal to scientific productivity. It's different. It's a different skill. It's a different world. And I think that that is something that we should keep in mind.
Okay,